Hello, and welcome to the Early Childhood Health Consultation September webinar titled Medical Urgencies versus Medical Emergencies. What's the difference and how to respond? My name is Maria Morgan, and I'm the project manager with Early Childhood Health Consultation. Our team is so excited for you have you join us today for the conversation. Our program is in partnership with the Wisconsin Department of Children and Families, housed at the University of Wisconsin-Madison School of Human Ecology, and funded by the Preschool Development Grant. Our program is committed to supporting Wisconsin early childhood education providers in supporting their questions on health and safety practices. We envision a sustainable and statewide model working through health consultation and centrally focused on promoting the health and well-being of children across Wisconsin. The Early Childhood Health Consultation Program acknowledges the American Indian tribal nations across Wisconsin and commits to a partnership to best meet the needs of each tribal community. The Early Childhood Health Consultation Program offers general guidance on best practices for health and well-being in early childhood settings. Any questions about a specific child should be directed to that child's primary care medical home. For today's webinar, we will begin with a few introductions, have centralized content, time for question and answer, and a few closing remarks. For those interested in continuing education credit with the Wisconsin Registry, stay tuned for the end of today's presentation, where we will include a survey link directly in the Zoom chat. That's the place where you'll enter your information for continuing education credit. You can expect any information directed to the registry following the event. Also following today's webinar, you can expect a post-webinar email, which includes a link to today's recording, as well as some resources. There are a few webinar features enabled for today's time. The first is the chat. Feel free to utilize that and enter your comments throughout today's presentation. You can use the drop-down arrow to send your comment either to hosts and panelists or to everyone. If you have any questions, feel free to utilize the Q&A feature. You can send the check mark to send it anonymously. And now I will hand it over to our program director, Dr. Dipesh Navsaria, to talk about today's objectives.
Good afternoon, everyone. Thank you for being here as always, and pleasure to spend some time today sharing information with you. Today, we'll be talking about the difference between urgent medical situations and emergent, meaning emergency types of situations. We'll be talking a bit about the most common types of emergencies that are present. Talk about how to prevent emergencies, because it's the best ones are the ones that we never have to have if we can help it, and talk about our own responses and reactions as adults working with children who may be in a situation where they're in danger, developing that confidence, and then of course the types of resources additional resources that we can offer here at Early Childhood Health Consultation. Speaking today will be myself chiming in, but primarily our amazing, awesome nurse consultant, Kelly O'Connor. Kelly, go ahead and take it away.
Hey, thanks for the introduction. Hi, everybody. Thanks for joining us today. My name is Kelly O'Connor. I'm a pediatric nurse with Early Childhood Health Consultation. When I'm not working for Early Childhood Health Consultation, I'm a pediatric nurse at American Family Children's Hospital in Madison. So today we're going to be talking about medical emergencies. And our intention with this webinar today is to provide you with information to help you feel empowered and to learn something new today. We hope that you'll go your whole career without encountering a medical emergency in pediatrics, but we do know that they happen. So we thought it would be good to talk about it today. Our intention isn't to scare you or provide you with scary information, but to empower you. So while we'll use terms today like most common medical emergency or be talking in depth about medical emergencies that happen, it's really important to remember that these are extremely rare. And like I said, I hope you go your whole career without being involved in one.
And, you know, I might just add here, even between Kelly and myself, I work primarily in an outpatient setting, meaning in clinics. So thankfully, I don't have to see too many kids who are having true emergencies. It does happen, but it's not too many. Kelly works in a hospital where emergencies are more common because the kids are much sicker and all. But having said that, even for myself, practicing and thinking about through scenarios helps me be more prepared for those rare times that an emergency does pick up.
Same in the hospital. We're constantly practicing and being prepared for when emergencies within the hospital happen as well. And so with all that being said, though, I did want to take a moment to recognize if you are someone based on your past experiences that has had a situation with a medical emergency in a child, and this information that you're hearing today becomes overwhelming or triggering. Totally understandable if you need to step off the webinar, and you can access this information at any time. It's all being recorded. But I just wanted to give you permission that if this information becomes overwhelming at any point, feel free to save the webinar for another time or not at all, depending on how you react to this kind of information. But again, our intention is to leave today feeling a little bit more empowered than you were before. So let's dive into the information a little bit here. So like we said before, we're going to be talking a little bit about the differences between urgencies and emergencies. Defined by healthychildren.org, a true emergency is when you believe a severe injury or illness is threatening your child's life or may cause permanent harm. In these cases, a child needs emergency medical treatment immediately. So it gets a little tricky, especially in kids, because there's not a clear line on when something becomes an emergency. Something that is emergent, every minute counts, and you need to start activating an emergency response team immediately. Whereas something that's urgent is something that needs prompt attention and intervention, but isn't necessarily to the point of where it's life or limb threatening. I think a good example here is a kid, for example, who has a condition like asthma. You notice they're working a little harder. It's a little urgent. They're working hard to breathe. They seem a little panicked. You know they have asthma. You give them their inhaler and they're back to their normal selves. So they feel good. That's an urgent situation that the intervention helped, and it's no longer urgent. Going in the other direction, let's say that same kid working hard to breathe, you give them their inhaler, they're still working hard to breathe, you follow their asthma action plan, give them another dose, and then all of a sudden their lips are turning blue, they're less responsive, they seem confused or aren't acting like themselves. That's when it dips over into the emergent section and when you need to call for extra help. I think another example that we could use, kind of painting the picture of urgency versus emergency, is in head traumas. There might be a kid who bumps their head on the table, falls over, starts crying, but within 10 minutes is acting themselves again, running around in the classroom, no issues. Whereas a kid who might fall from a higher distance, becomes confused or is throwing up or isn't acting themselves anymore, that would be in the emergent category. It's good to kind of assess each kid based on what their baseline is and how is the kid acting. So those were a couple examples of things that would be classified as emergencies. But healthychildren.org actually has this whole list of signs that your kids might be showing if they are in an emergency situation. So we'll kind of take some time here and dive into these. So warning signs would be strange or more withdrawn, less alert behavior. Again, they're not acting themselves, indicating that something else is going on. Unconsciousness or no response when you talk with your child. Rhythmic jerking, like a seizure. And we'll talk about seizures a little bit more again later. And if a kid does have a seizure, kind of planning that goes into that when they're in your care. Increasing effort or trouble with breathing. Again, we'll talk about this a little bit more later because that's the most common reason kids will get in trouble. It tends to be respiratory illnesses or issues. Skin or lips that look blue, purple, or gray, meaning that they're likely not breathing well. Neck stiffness with fever, that indicates meningitis. So here's kind of that spectrum again of, oh, a kid has a fever and they are running around. I would have never have guessed that they had a fever. That's okay. A kiddo that has a fever, isn't acting themselves, and is also reluctant to move their neck at all is something that we would want to be addressed right away. Increasing or severe persistent pain. A cut that is large, deep, or to the head, chest, or abdomen. The reason Caring for Our Children shouts out those specific areas is because they harbor, I guess, a lot of sensitive organs that we want to make sure are okay if there's a deep cut in those areas. Bleeding that does not stop after applying pressure for 5 minutes. And when we say applying pressure, we don't mean just a little hold and peeking every second to check if it stopped bleeding. When you're holding pressure, you're doing a firm handshake kind of pressure on that area, and you're not peeking for that full 5 minutes. A burn that is large or involves the hands, feet, groin, chest, or face. All those are sensitive areas that need to be addressed, and larger burns can lead to bigger problems. Any loss of consciousness, ongoing or worsening confusion, headache, or vomiting after a head injury. So if you kind of look at all of these situations as a whole, these are all things that you should rarely see in children if you've seen it at all. And would all things that in your gut you would feel, that's not right, I need some help now. Dr. Navsaria, anything to add here?
Yeah, Kelly, it's so interesting to me because in an outpatient setting, I so often hear families coming in with concerns. Is my child badly injured? Is my child, is there a massive infection going on that needs immediate intervention? And so on. And so rarely are they actually those awful things. And then the few times I do see these things, it's the sort of thing you walk into the room and you notice immediately, right? Because they are so rare when they're this severe and this unusual. And that's not to say we should blow people off by any means, but it's just to highlight that often you'll know it because it's just something we see so rarely.
Exactly. Especially hopefully in a school or early childhood education setting. So next, like I said, we would dive a little bit more into respiratory because this tends to be a big one in kiddos. In adults like you and I, cardiac tends to be the main reason for emergency or hospitalization. And for kids, it tends to be respiratory. And there are a few reasons for that. Well, we all know that kids aren't just tiny adults. Their bodies and their structures, their feelings, everything about them is different than an adult, especially when it comes to their airway. Their airways are proportionally smaller than an adult's. Their airways also tend to be floppier, less rigid, and less capable of clearing and handling mucus, which is why when kids get viruses, sometimes they get really sick, whereas an adult will have the same virus and will be able to totally manage it, no problem. And you can see in this picture here in that bottom left-hand corner, the top two are, that's an infant airway, and the bottom is an adult airway. So you can see in the infant airway, the one in the top right corner, that's an infant airway that's lined with mucus. And you can see how much proportionally that mucus is taking up of the infant airway compared to the adult one below it. So that's why we worry about kids more when in the hospital with respiratory illnesses. And also, like I said, that they're floppier, they're less rigid, like an adult airway can handle more mucus because it's more rigid. Young babies also breathe through their nose. They're what we call obligate nose breathers. That's just for the first few months of life, but it's just an interesting thing to note when you see a young baby. An adult, or an older kid has the backup of breathing through their mouth, but a young baby doesn't have that. So that's why we're so frequently recommending to suction out noses for really young kids. So next we'll kind of jump into preparedness. Caring for our children actually has a lot of great information about being prepared in early childhood education settings. This first box here from Caring for Our Children talks about being prepared with kids who have specific medical conditions. For example, like we were talking about earlier, seizures or asthma. There should be a care plan that is created by parents and in combination with their primary caregiver to give to you as their educator in case something happens while they're there. A lot of kids have these known medical conditions that could lead to emergencies, and you should be provided from the parents a very detailed list of what to do if the kid is going through one of those emergencies. Something like that would look for a kid with a seizure disorder. If they are seizing for this long, give them this medication, and then steps after that on what to expect. Or a kid with asthma, if they look like this, give them this dose of an inhaler, and then again, subsequent steps after that. Each kid will have a different plan because every kid is different. And that's why pediatricians are so great. They're able to make curated plans for each kid that the family and teachers can follow. And the next boxes are kind of talking about generalized medical emergencies. So all staff needing to be trained to manage an emergency until emergency medical care becomes available. And I think it's important to mention that it's not your job to fix it. We don't expect people who aren't medical professionals to fix the problem, just to initiate the emergency response system and to provide first aid the best you can with the tools that you have until they get there. The next section talks about written emergency procedures and policies should be reviewed and practiced regularly. And if something about the facility or the kids or the staffing ratios change, it's important to address those pre-written, those pre-discussed plans and make sure that they still make sense for your facility if your facility has changes. Some kids too will develop conditions as they go. And again, you should be given a plan that makes sense for that kid. And it's just good to come together as a team at the beginning, like at least annually, according to Caring for Our Children, to re-talk about those and get training for new staff.
This is where I'll just highlight that everything that was on the slide you just saw is not something that you sit and talk about when the emergency starts to happen, right? This is all preparedness. This is all something you sit down in a team meeting, think about, talk about, plan, and do so before you need it.
Exactly. And so now we'll talk a little bit about, okay, so the emergency is here. We've defined its emergency. We've discussed a plan in the past. Now what? And again, this is all guidance from Caring for Our Children. They have a lot of good information out there about this. So your first step is to begin first aid the best you know how, and contact should be made with the emergency medical response team like 911 or poison control. While you're doing this, kind of depending on your facility, all of this will look a little bit different. If you're at a big facility with a lot of adults you can't around, calling for help and getting as many adults around to help you is key. But that might look different if you're in a home care setting and there's only a couple of you. But again, that's why it's really important to have those discussions about what you would do if there was a medical emergency. And then so when you make that call, the first thing that 911 will ask you is for your address. So it's really important if you're working at a new facility or you don't know the address, have it memorized, because that is the thing that will get the help you need there as quickly as possible, and not delaying for a couple minutes being like, wait, what's the address here? Because as soon as they have that address, help is on the way. And then next steps, plans to transport the child to a local emergency medical facility should also be followed. With this being said, it should also be discussed who is going to go with that child when you're planning out your emergency plan, hopefully before all this happens, who's going to go with the kid. Also alerting the parents and guardians that the emergency has happened and that they should go to that emergency facility that the kid is being transported to immediately. Again, the third one saying a staff member should accompany the child to the hospital until the guardians can get there. So again, that will look very different depending on the kind of facility that you're working at. And then the last one is talking about debriefs and changes that should be made. So the reason we say at the beginning, get as many adults involved as possible is because there's a lot of different roles that go into medical emergencies. So if you're working at a very big facility, when EMS, the medical emergency services arrives, they might not know exactly where the playground is or exactly where classroom A is, or the sun classroom. So having someone to meet them at the door is a really good role to assign. Second, I just wanted to also mention that the person who's tending to the child that is ill or going through the emergency, that should be their only job. The rest, other adults around should be assigned other roles like calling the parents, meeting EMS, and keeping the other children calm. A lot of times these tend to be very chaotic situations. So keeping the other children safe and in a good or as most calm as best as they can be is a really important role. It's important in these situations because kids will be really scared. Mr. Rogers' quote, "Look for the helpers," is a good way to make these experiences less traumatic for the other kids involved. So pointing out, this teacher is helping your friend and they're getting them all the help that they need right now. And things like that are good phrases to use with those other kids. And again, this is going to look different for different facilities. So if you work at a smaller, in-home care facility and there's only 2 adults, it's good to talk about what would that look like to keep the other children safe while all of your attention is on this one kid. Is it going to have to be letting kids cry and pack and plays while you're tending to this emergency, and then the other adult is calling parents? It's all good things to think about and plan through. Dr. Navsaria, anything to add here?
Yeah, I want to highlight a few things from that excellent set of descriptions and considerations that you laid out there. One is it really may seem silly, right? Like, gosh, we need to assign someone to be by the door to guide them in. But, sometimes the buildings are confusing. Let's not make them go hunting for what's going on. I think many of you know that I have heard me mention that I'm a summer camp physician every year. One of the things I've learned over the years is if you're calling EMS, assign someone to go up by the camp gate and point them in to the right place so they're getting to the right building, and things like that. So that certainly makes a big difference. And then, yeah, thinking about the other kids is important. Recently, I was at a conference where I responded to a medical emergency. It was a bee sting in someone who was quite allergic to bee stings and did not have a EpiPen with them. And it actually was the spouse of a colleague of mine. Now, there were about 4 other physicians that responded, and EMS was called. Someone was looking for an EpiPen, et cetera, and this was an adult. So I decided as a pediatrician, I could afford to step back and let the other doctors tend to the person who was affected. I ended up walking just outside the building where their young kids were, and there was someone watching them and talking to them and all. And I spent a few minutes talking to them. They were obviously scared and crying and all that. And exactly what Kelly described, I said, look at all these people who are coming to help. And I can hear the ambulance coming already. This is all going to be fine. And explaining and all. Because I felt that was the best role I could play there. Now, if there's just a couple of you, you may not be able to tend to that immediately. Totally get it. But if you have other individuals, that does make a difference. And I do want to highlight that even in hospitals, we do the same sort of thing, get a lot of adults in the room quick. We ring the alert chimes and basically everyone and their brother shows up. And then you send away the people that you don't need. Right. But you want to make sure you have the right folks for something that is a deep emergency like that. And again, planning and thinking through this, what would we do? Who would go and guide EMS in? Who's going to call? Some of you may work in rural locations where the address may be a little difficult to figure out. I would actually recommend having the exact address that EMS needs posted by your phone. So that even if it's a visitor who's there, who's making that call for whatever reason, they're not sitting there going, wait, which township are we in? Because that's sometimes not always obvious, and things of that nature. Think through, if an emergency is happening, what are all the steps and how do we make it as easy as possible for everyone to do the right thing?
Thanks, Dr. Navsaria. Next, we'll touch base a little bit on first aid training. So I just want to highlight again that when a medical emergency happens, your role isn't to fix it, it's to initiate the medical response team in your area. And first aid training is a really good tool that you can utilize to bridge that gap between, okay, there's an emergency, I'm here with this kid, and by the time the medical emergency response team gets there, the American Red Cross has a really good training video. We put the link here if you want to check it out. It's just something that if you're interested in being more prepared for this kind of situation, it has a lot of good tools in it. And I know that it's, I believe everyone on this call would be CPR certified as well. There's a lot of tools within CPR certification that apply to medical response as well. Even if you're not doing CPR physically on a kid, that kind of flow of how to respond in an emergency situation is applicable as well. So next I want to talk about staying calm and bringing a calm energy to your pediatrics or to your kiddos. We all know that when you panic, a kid panics. They're looking to your face as the adult to know if they should be scared or not. So I'll just read this quote here from Healthy. Is this one from? Yep, this one's from healthychildren.org. So when you panic, your child's anxiety level goes up. For many kids, anxiety about what's going to happen is worse than the actual pain. Children of all ages look to their caregivers for reassurance, so it's important to keep communicating. Be honest, but also be sensitive to the situation and his or her age. Let your child know that everyone is here to help. A lot of strangers will be involved in these medical emergencies. So having an adult with the kid that knows them really well, that they can focus on and look at their face and help distract, is a really good tool to have in these situations. And we don't need medical emergencies to practice this calmness. A lot of situations in early childhood education become stressful. So we can be practicing bringing our calm to overwhelmed kids in our everyday lives. And the more you do it, the easier it becomes, especially for stressful or potentially hurtful situations. And I also wanted to hone in on a little part of this quote that's really important. It's important to be honest. So if it's going to hurt, it's okay to say this is going to hurt and I'm here to help you through it. Things like that are important. It's important not to lie because that's how they build a trusting rapport with adults is, okay, they said that it's going to hurt, but I feel like I can get through it because I have my adult here with me. Next, we'll move on to prevention, which is my favorite thing to talk about because it's much better to not ever have to deal with any of this because we prevented the medical emergency. That's always the goal, no matter where you are. If you're in an outpatient setting, in a classroom, in the hospital, in urgent care, wherever you are, prevention is best. We love prevention. So this is a pretty fun graph I found about sudden unexpected infant death. And the line I want everyone to focus on is that purple line on the top, which is the combined SUID rate or sudden unexpected infant death. You can see that the graph starts in the early 90s. So I just wanted to point out that a lot of education and policy around safe sleep started in the early and mid 90s and rolled out through pediatricians and through policies. So I just wanted to kind of take a moment for everyone to recognize that, you know, all the policy that you have around safe sleep for your care centers and all the regulation all work to contribute to this positive number, this decrease in sudden unexpected infant death syndrome, that the things that we do are working. While many kids are fine, some aren't. And this graph shows that that our actions have improved the health, well-being, and overall outcomes for pediatrics in the realm of sudden unexpected infant death syndrome. Sorry, tongue twister. Another prevention we want to talk about too was around cars and car accidents. You can see this is a similar graph where numbers are improving. There's less severe injury happening here with the increase in safety of cars, more technology around booster seats and car seats, all a great thing if we can just prevent the injury by having all those things. So falls are the #1 reason for hospital admission in an emergency room. So the more we can do to prevent those kind of things is better. So whether that's seat belts, protective gear, booster seats, all that.
I'll also add that it's even things as quote unquote simple as behavior changes. Somewhere in this data, I'm not going to remember the exact year, but was the recommendation to have children rear facing till 2 years of age, which again, we heard a lot of people saying, oh my goodness, I can't see my kid, this is harder, the seat doesn't fit properly, et cetera, et cetera. But when you look at the data, right, it shows that yes, that actually did and does save lives. So it's not just improved technology, it's also improved knowledge about what behaviors improve things. Same around safe sleep.
And next slide is touching base on safer play equipment. So here we can see 2 pictures. One is a set of old play equipment, and the second on the right is new play equipment that was implemented in the specific study that we found when I was searching around. So this study in particular showed that the removal and replacement of unsafe equipment was an effective strategy for preventing playground injuries. And so we're never going to take away all injuries. It's a rite of passage of childhood, right? You're going to fall, you're going to get hurt at some point, and that's part of growing up. You learn how to deal with injuries and being hurt. But our goal as responsible adults is to reduce the number and intensity of those incidents. Like I said before, unintentional fall is the #1 cause of emergency room visits in all age groups from 0 to 80. So we can prevent some of those emergency situations with protective and safer gear. Something that I think that I hear a lot about in the pediatric world, and I'm sure you do too, is like, oh, are we being too easy on kids? Or the back in my day, I, did this and I turned out fine. And while that's true, most people are fine. We know that some aren't. And I think that it's good to have the context of we're reducing the number and intensity of incidents. We're not putting kids in a bubble and saying never play or don't, scratch your knee or something like that. We're just trying to keep as many kids as possible, as safe as possible, so they can grow, develop their motor skills, and be the best versions of themselves they can be for all kids. Because while that saying of, well, back in my day and I was fine, yes, most kids are fine, but we do know based on studies that some aren't, and these protective measures do make a difference. So now let's talk a little bit about how our bodies respond when we see a kid in danger or we are responding to an emergency situation. So if you are someone who's thinking, nope, I don't do blood, I don't do puke, I'm not a nurse, I'm not a doctor, that ain't my thing. The good news is we have a hormone called adrenaline that every person has in their body. And when we see a kid in danger, as an adult, we get a rush of this adrenaline. That adrenaline makes us hyper-focused, and your body kind of forgets about all those other anxieties it has, whether it's blood or puke, whatever it may be. Your body just kind of forgets for a little bit. And you get this really big dump of this hormone into your body so that you're able to hyper-focus and do everything you can to help this kiddo. So with that being said, if you do ever respond to medical emergency, you might be feeling really ramped up that day because your body is processing all of this really intense hormone. But then over the next several days, you might feel a crash from all of that adrenaline coming out of you. And you might feel really tired, more anxious, have a lot more feelings. So I just wanted to point out that it's really important to process what you saw with another trusted friend or adult or even a health psychologist. Our brains aren't really wired to see kids suffer. We're not meant to be able to process that easily. So it's really important that you take care of yourself after you've responded to one of these situations and get help you need to help process it.
I'll give you an example that actually happened just last night. I was in urgent care. A child was brought in who had suffered a small laceration, a cut on their forehead. It had happened not all that long ago. Mom and dad were there. Sibling was there. Child had been bleeding quite a bit. Facial things do tend to bleed a lot. That's normal, but it can be scary. And now that he was there and cleaned up, we could evaluate him and decided that he didn't actually need stitches now that we could see what was going on and so on. He had a lot of drops of blood on his top, obviously, because the blood had just been gushing down. And his dad, who was sitting off to the side, suddenly got really like, whoa, and then kind of slumped back a little. Turned out, as mom informed us, he also has diabetes, so that's the first thing you're worrying about, right? But his blood sugar was fine. He was fine. He was there for his kid, right? The adrenaline, everything Kelly just talked about was there, and he held it together. And now they're safe. They're being evaluated. Kid's okay. And then suddenly he's looking, and I think he's just like, oh, my kid was bleeding all over. And he suddenly had all that emotion of like, yikes, my kid was bleeding this much, came out, and just made him feel really lightheaded. They were all fine. They left about 15 minutes later and all happy. But this response, this reaction, is a very normal human response, and it's just important to recognize that it's normal and that it can happen.
So now we want to talk a little bit about systems approaches when a medical emergency happens and the importance of blame-free debriefing. So, and this doesn't go for necessarily medical emergencies, can go for any injury, anything on that spectrum of kids being injured. So for example, let's say a toddler is walking around or, bobbling around, hits their head on a table, cries for 5 minutes, and then they're fine. You could come together as a team and be like, wow, the way we have this room laid out, maybe we could make it better. Maybe we could make it safer. Maybe we could add some padding here. What could we do as a team to prevent this from happening again? That would be a positive, systematic approach to making an environment safer. A kind of unhealthier way to handle that would be, who is supposed to be watching this kid? How could you let this happen? Don't you know that those edges are hard? That would be an unhealthy example of how to handle it. Whenever injury or accident or emergency happens, it's never one person's fault or one thing's fault. It's typically a systematic thing that we all need to come together to make better. So it's important to come together as a team and have those discussions, even with just minor injuries, of what can we do as a team to make this better for kiddos.
This is really important, and I just want to highlight how often this is used it's used in healthcare, it's used in police, firefighting, all sorts of different places. Often the person leading the debriefing is someone who is not involved directly in what happened, or is not necessarily even a supervisor. It may be someone else entirely. So that way it takes the focus off of, who's in charge and who's, reporting to who. And it really is about, let's walk through this. The first question being one of the things we talked about earlier: how could we have prevented this, right? What possible changes could be made? Doesn't mean you can necessarily run off and do them. Sometimes it's like, well, we could have done this, but man, we have no money for that. Okay, but at least you've identified that it's a need, and maybe you can get to it at some point. Walk through prevention, walk through how could we have made the injury less severe? What was the response to the injury? Was there a delay in calling EMS or calling whoever, or having something available or ready? Okay, great, we can fix that for our process next time, and learn from this. And the next time something like this happens, we'll be better prepared and better equipped. And it's all about changing up the systems and building all of our skills, not looking to seek blame. That's the most important thing about these debriefings, is that this is not about pointing fingers.
Absolutely. And recognizing that all of our coworkers and we're all just doing the best we can with what we have. So next is references. You'll notice a lot of these come from healthychildren.org or Caring for Our Children. Lots of great information out there. So if you're looking to dive deeper into anything we talked about today, a lot of these links have some really good information. So if any of it interests you, I encourage you to take deeper dives here or reach out to us as always with any questions or concerns. And I just wanted to say, take a moment to say thank you for all you do for the children of Wisconsin. I appreciate all of you so much, and thanks for joining us today. I always enjoy these webinars and talking with all of you.
Thank you so much, Kelly. We'll be happy to take any questions that you might have. We have our eyes on the chat as well as on the Q&A feature, which again is accessible through that button on the bottom of your screen there. And we'll give you folks a few moments if there's questions that are occurring to you, chat, or we will always accept your gratitude and thanks in the box as well, because it makes us feel good. So. Kelly, while people are thinking about things here, it does really highlight to me so much how how many of these same things we do in healthcare. These same principles and processes that are out there. So we have a question. Best way to store EpiPens for the more common allergies like peanuts or milk? Any thoughts on that?
What was the question one more time? Best way to store?
Store EpiPens. Mm-hmm.
Huh. I guess, you know what? I'm not sure off the top of my head. I wonder, I bet that there's instructions with each EpiPen on how it specifically needs to be stored, whether it's refrigerated or not.
Mm-hmm. Yeah, so they generally don't need to be refrigerated, but like with any medication, you want to be careful that you're not exposing it to extremes. So sometimes, for example, if people have allergies to bee stings, right, they'll think, oh, I should keep an EpiPen in my car, right, in the glove compartment, because then if we're hiking or something, then that's the closest place I can get to it. Well, think about what the inside of a car is, right? Like, it gets really, really hot in the summer, really cold, in the winter. That it may affect the potency of the epi in there. So certainly in a classroom setting, the extremes are less, but trying to make sure it's not sitting out in the sunlight. Those sorts of things make a difference. I've heard some people sometimes actually store the EpiPen inside a thermos. Because that way, if there is a big temperature change, the thermos will avoid some of that. I'm not sure we have deep studies or science on that, but it makes sense. And then, of course, checking those EpiPens on a regular basis just to make sure they're not expired and replacing them if they are. That's a part that we often forget. I see another question here about anything we need to know about seizures. Kelly,
So there's a great podcast that Dr. Navsaria just did that I recommend everyone listen to. It was really fantastic that will dive into a lot of that. There is a lot of ground to cover in seizures. So I'm hesitant to dive into a lot of it right now. Dr. Navsaria, anything quick you have to add?
Thanks for the podcast plug. I'll just put the URL in briefly into the chat here, and it's episode 5. If you're interested in listening to that one, I'd say the short version is 1, don't panic. 2, make sure the child is in a safe place so that they don't fall off a table or changing table or something like that. So on the ground is maybe the safest. And time how long the seizure is, and also call for help. Have someone calling for help. Look, if EMS shows up and the seizure was only 30 seconds, and they judge that they may not need to transport the child, that's okay. EMS is happy to show up and say, I don't think we need to transport this individual. They would rather that you err on the side of caution if you're not sure. That's the short version, I think, on seizures. There's a lot that we covered in that episode of the podcast, so feel free to listen to that. Another question here for injuries. Could we do the basics like gauze and wrapping until EMS arrives, or just pressure and a gauze? Bleeding, lots of blood. What should we have people do, Kelly?
My recommendation is that pressure that you can hold with your hands will be stronger than anything like a gauze or tape or whatever can apply. So just think to yourself, apply more pressure than you think you need to. It's best to do it without peaking as well, because that's going to disrupt any clotting processes happening. So if I was in a situation with intense bleeding that needed EMS call, I would be holding pressure as hard as I can until they got there.
And let me emphasize that steady pressure and stop checking. Every time you move, see, people often think that clotting happens and then it's done. Clotting is a long-term process that actually happens over days in terms of strengthening. So if that clot starts to form and you lift that gauze to see is it still bleeding, you may disrupt it and now more blood. And then everyone says, oh no, the bleeding won't stop and won't stop. That strong, steady pressure is going to be your best friend there. So definitely agree with the gauze or anything else. And just hold that pressure and let us worry about it in the emergency room or urgent care or wherever about, getting it off and looking more carefully at it. That's our problem, not yours. Let's see. At what point does a child's fever require emergency medical attention?
Yeah, so fevers are a tough one, right? And I know we mentioned earlier fever with neck stiffness is urgent. It also depends on the age of the kid. For between the 2 and 4 month mark, we have a different threshold than kids who are older. Dr. Navsaria, do you want to dive into that a little bit?
Yeah. So the first thing I'll say is, for the most part, the except for those kids that are younger, the younger infants that you just mentioned, we generally, there's not a number that we say, oh, this is automatically a problem. And that's the hard part. I wish it worked that way. Wouldn't it make our job so much easier, all of us? But the question really that we always often come back to is, how's the child behaving? What other symptoms are we seeing? A kid who's running around playing with 103, I'm not too worried about them. The kid with a normal body temperature who seems slumped over and like not responsive, I'm worried about them. So there's not a number that we actually fixate on in most situations. Any fever, meaning anything that is 100.3 or above in a young infant, so a kid under 3 or 4 months, should be evaluated, just because there's a higher risk that they do actually have a serious condition. And I will say, if you go back to our video library at prior webinars, and I'll put that link in the URL right now, we have covered some of these things. The February webinar on fever, breathing, and pulse ox, oh my, we discussed and delved into fever some more as well. So those are all available online, so don't hesitate to go back and check those out if you didn't, or if you just want a refresher or want to share with your colleagues who may not have seen these yet.
An important note about temperature taking too: never add or subtract any numbers. The number that you see is what it is.
Thank you. I've had kids come in only for a fever that wasn't actually a fever. So don't go adding or subtracting or square roots or any other fancy math on those numbers.
Make it harder than we need to be on ourselves, don't we?
I'm not seeing any further questions in the Q&A or chat at this point. Of course, if anyone has further questions that occur to them later, we will be telling you in a moment how to contact us. I'll turn it back to Maria.
Great. Thank you, everyone, for your engagement into today's webinar. The Early Childhood Health Consultation Program is here for you. We're here focused on health and safety promotion within early childhood care and education settings. And how we do that is through numerous ways that you can see on the screen. The first is webinar trainings such as this one today. We also have an on-demand resource library found on our website. As mentioned in today's webinar, we also have a podcast titled Teachers, Toddlers, and Tissues. Feel free to check it out on wherever you stream your favorite podcasts. And also, we have tailored health consultation services. We are excited to announce that we've recently expanded these health consultation services to even more communities across Wisconsin with the aim of statewide support over time. If you're interested in finding more information, you can see all these specific locations on our website. We're excited to share that episode 7 of our podcast just launched yesterday. So if you haven't checked it out yet, we invite you to tune in and listen to episode 7. There's numerous ways to reach our team. In a moment, these details will be put into the chat. Also, you can reach out to us on our website for these contact informations. Phone call, text, email, and social media are also available. Special thanks to the many early childhood care providers who offer us ongoing guidance to best meet the needs of the children they serve, including our very own advisory board. We'd like to thank our colleagues from other health consultation programs across the United States, our current project partners, and our past project team members. A few reminders following today's webinar. At the end of today's event, we will include a survey link in the Zoom chat. This is a great place for you to enter information on continuing education credit with the Wisconsin Registry, and also to give us feedback on how we can improve future webinars. Following the event, you can expect a follow-up email with a link to today's recording, as well as a copy of the survey link just in case you need it. And then following the event, any information entered on the post-webinar survey will be entered by our team to the Registry for Continuing Education Credit. We invite you to save the date for our next webinar on October 5th from 1 to 2 p.m. You can learn more and register soon on our website. So I'd like to direct your attention now to the Zoom webinar chat. This is where you can find the Qualtrics survey link to offer us your information for continuing education credit, as well as give us feedback on how our webinar went. And with that, I will turn it over back to Dr. Navsaria for closing remarks.
Thank you so much, Maria. And thank you, Kelly, for the excellent presentation today and sharing your expertise and perspective on how to handle emergencies. I'm hoping everyone is leaving here today with a sense of calm and confidence about how to handle these things. I do want to highlight again that please, the other webinar episodes are available online on our website, as is the podcast. We try not to overlap the podcast and the webinar topics too much, but there's a little bit that's there that does overlap over time. But it's a different format and a different way of covering a lot of this information. And please tell your friends all of the stuff that we share. We'd like everyone to benefit from it. And again, thank you so much for all the work and hard work and care that you provide to the children and their families throughout Wisconsin and beyond. We really do appreciate it and value everything that you do. Thank you very much.